October 3rd. And it's being recorded, as you know. And please use the Q&A button or the chat for questions. Next slide. So we have some very interesting presentations involving pregnancy and COVID, but first the next 3 weeks presentations. We'll have a presentation from Jiming Sun involving machine learning models, fusing medical knowledge and machine learning models for early pediatric COVID-19 hospitalization and severity prediction, and sort of interpretable machine ML AI is obviously very important, particularly in the context of COVID, but really in the context of all of medicine. So that should be very interesting. Acute upper airway disease in children with Omicron B11529 report from the N3C consortium by Blake Martin's going to be talking, and then extracting patient level social determinants of health into OMOP the next week, and 31st is to be determined. Next slide, please. Okay, so we're about the same. I guess these things get updated every now and then. 6.5 million COVID cases. I guess one gets inured to that with millions of individual data elements. Next slide. Okay, so our presentation, number of presentations from the pregnancy team, phenotyping in pregnancy, as well as vaccine effectiveness in pregnancy. And who's going first? Rena, are you first? No, who's first?
Kate Bradwell will.
Kate. Okay. All right, Kate. So Kate, looking forward to it, and you're sharing your slides. Great. Okay.
Okay. So over the past couple of years, I've been working with the pregnancy domain team on the phenotyping pregnancy side, so defining start and end dates of pregnancy in the N3C data. So that's what we're going to present for the first half, and then Crystal Quinn, who has been working in the pregnancy domain team as well. She's going to present a use case for these pregnancy episodes that we defined, and showing an analysis on vaccine effectiveness in pregnancy. So we really needed to design an algorithm to define the pregnancy cohort and precise pregnancy start dates, and then validate those pregnancy episodes that have precise pregnancy start dates using the clinicians that were part of the pregnancy domain team. And then we aim to describe that cohort of women that have the pregnancy episodes in terms of COVID-19 during pregnancy and other covariates that are of interest to COVID-19 research in pregnant women. So this effort, it was a 2-year effort of defining pregnancy episodes within N3C and creating this composite algorithm that we called HIPS, was actually coded by myself and Sarah Jones at the NIH. And we got a lot of feedback from clinicians in the domain team, and they had a very precise kind of task order for us. They wanted very precise gestational timing in terms of the pregnancy episodes that are defined for specific reasons. So many outcomes are just gestational timing dependent. Also, exposure outcome relationships are linked to various stages of fetal development. So it is very important that we define these pregnancy episodes with, where possible, within a week level of precision in terms of gestational timing, and have very precise start dates for pregnancy. So this was this presented a challenge because in N3C, as you all know, there are various concepts which present a certain level of missingness. And in the case of defining pregnancy, this presented even more of a challenge because some of the concepts that you would expect to be present to be able to precisely define gestational timing in pregnancy weren't present. So we had various scenarios in the data. This first row presents the ideal scenario where we have pregnancy detection concepts, we have antenatal visits, variety of concepts defining the maternity and antenatal visits during pregnancy. We have delivery, and then we have postpartum follow-up. But what we're seeing in a lot of cases were these three other kind of rows where you might have only antenatal visits and delivery, such as live birth or stillbirth or spontaneous abortion. And then you might have postpartum follow-up, or you might have the delivery missing, or you might have antenatal visits missing and only the delivery present. So this really makes it challenging to define when the actual start date of pregnancy occurred. So to address this, we came up with, as I said, the HIPS algorithm. It's a composite algorithm composed of three sub-algorithms. First two were inferring pregnancy episodes, and the third sub-algorithm defines precise pregnancy start dates. And overall, there were about 10 steps, and I'm going to break down these the main steps of this composite algorithm in the next few slides. So we start with actually finding an initial pregnancy cohort. So that means selecting OMOC concepts and selecting patients. So it began with first obtaining a population of persons actually eligible for pregnancy. So this for us meant female gender and age 15 to 55. Then we filtered to persons that have clinician curated high confidence pregnancy concepts. So these were ultrasound concepts and outcome concepts, pregnancy outcome concepts such as live birth, stillbirth, spontaneous abortion, etc., that we felt were very high confidence and had been used in a previous study that defined pregnancy episodes in EHR data. And so using the group of women that had those high confidence concepts, we looked for further concepts that were specific to that group of women and not present in everyone else, or very low prevalent frequency in everyone else. And that allowed us to define a further set of concepts to bring the total to 1,417 pregnancy-specific concepts. And then we gathered initial gestational timing concepts and further pregnancy outcome concepts through searches via Athena and other tools online to figure out if there were further concepts that we could find, and in the literature as well, that defined pregnancy outcomes. And then we filtered to the persons that had any of the resulting pregnancy concepts to obtain what we call the initial pregnancy cohort to use as the input for our composite algorithm to define pregnancy episodes. So this first algorithm that we applied, this was designed and implemented by Sarah, and it's called the hierarchy-based inference of pregnancy, HIP algorithm. And these are the main steps for this algorithm. If you have questions on the detailed steps, please feel free to ask in the Q&A. It basically was composed of defining outcome-based episodes using an outcome hierarchy defined in that previous study. So, for example, if live birth occurred around the same time as stillbirth, then live birth took precedence and we defined the outcome for a pregnancy as live birth. we also used term duration information, so defined the possible maximum and minimum start of pregnancy based on how long you would expect the pregnancy to be based on the outcome you're seeing of the pregnancy. And then she defined gestation-based episodes using the concepts of gestation period X week and gestational age in weeks concepts from the measurement domain table. And then she found the overlap between gestation-based and outcome-based episodes, or the union, sorry. So combined both types of episode, and then did various checks on outcome date versus gestation-based episode end date, retry periods. So when one pregnancy ends, there has to be a minimum amount of time that a subsequent pregnancy can start. So that's the concept of retry periods. And so she checked between the episodes whether a sufficient retry period had taken place. And then also removed or cleaned up the episodes based on overlap to other episodes. So that algorithm defined our first kind of batch of pregnancy episodes, which we could then learn from and actually find further gestational timing concepts based on those episodes. So given the start dates estimated by that initial batch of episodes, we could say what other concepts are occurring which look to be gestational timing specific in the data. So we could say, does concept A always occur at 5 months after the start dates of these episodes defined by the HIP algorithm? If so, this is a potential gestational timing specific concept. And we then gave it to clinicians to manually curate and say, yes, we confirm that this is a further gestational timing specific concept, which could be used to further refine the algorithm and define gestational aging to more precisely. And then also from that initial set of episodes, we were able to say, what's the amount of error that we are seeing? So for example, concept A should occur at month 5 during pregnancy. Concept B should occur at month 7. So we expect a 2-month difference between those concepts. Are we actually seeing a 2-month difference in the record dates between those concepts in the episodes? And the amount of variation that we're seeing, variance that we're seeing around those expected time periods gives us an idea of what the buffer we kind of need to add in if we're going to be looking for a progressing pregnancy using those further concepts that we've found with the initial set of episodes. So looking in more detail at what we're seeing based on the initial, the concepts from the initial episodes, we, on the x-axis here is the mean observed month derived from the pregnancy episodes. So each dot is a concept. So for example, gestational age, 30 weeks. And the y-axis is standard deviation a month of when those concepts occur from the start date from the HIP algorithm episodes. So you'll notice that there's actually a trend that when you get later or more progressive later during pregnancy, you start to see more precise timing of the concepts of when they occur relative to the start dates. So we believe that these later concepts occurring later in pregnancy are actually more precise at determining gestational aging. But using this information, we applied a cutoff and found further concepts which we determined via clinician manual curation as well to be gestational timing specific and appropriate for improving the algorithm and using the concepts to define gestational age in a more precise way. We also looked, for example, at concepts which occur potentially over a range during pregnancy. So, for example, any concept that occurs at a specific point in pregnancy, but plus minus a certain amount of weeks. And so these concepts we plotted using in the box plots that you see, and their range that they're occurring during pregnancy generally falls into the start in blue and the orange, the end in orange, that the clinicians expect that those particular concepts to occur during pregnancy. So this is kind of confirming from the data that these concepts are occurring over a gestational age range that we expect during pregnancy. So given all that, and given the further concepts that we had defined, we applied our second algorithm, which is the pregnancy progression signature algorithm. And so that's applying a more detailed iteration over the concepts and saying, do we actually see a progressing pregnancy occurring? And that lends more kind of confidence to the estimates of or inference of episodes. So with this algorithm, we started with the 74 gestational timing specific concepts that we had attained via looking at the HIP algorithm initial episodes. And we looped through those concepts for each person and determined whether the actual difference in dates was within the minimum and maximum plausible expected months for the concepts. And I'll show the exact examples of the exact iterations in the next slide. And then we cleaned up the episodes, for example, removing any episodes with length more than 12 months, and also removing patients that had more than 5 episodes in 1 year. So examples of these iterations are shown here. In the first example, we've got to record 3 for a patient. And this is a gestation period 39-week concept. And so we actually perform 2 checks. So the first check performs comparisons to the current concept in every previous concept. So record 3 versus record 2, record 3 versus record 1. And the second check performs comparisons surrounding and progressively outwards from the current concept. So record 4 versus record 2 and record 5 versus record 1. And it says, if any comparison evaluates to true, i.e. the actual difference in dates equals what you expect the difference in dates to be based on the nature of the concepts, then continue the current episode. So this isn't the start of a new episode, this is a continuation of an existing episode. In the second example, we get to record 4 in a patient, and we perform all the checks, and none of the checks evaluate to true. Also, we see that the minimum retry period for a new pregnancy has been satisfied. So there's a sufficient amount of time from a previous concept to this record 4. And so based on that, we determine that it's the start of a new pregnancy. And so in this first example, we were able to define full 9-10 month time span of the pregnancy. And the second one, we determined that the record 4 was the start of a new pregnancy. So then we applied our final third algorithm, which was for these episodes that we had inferred, adding a precise start date. So that required another detailed algorithm layered on top of it, using the information from each episode. So we call this the estimated start date algorithm. Basic steps for this were obtain a maximum and minimum plausible start date for each concept within the episode, determine overlap between concept start date estimates from the concepts, and select the most likely start date from the overlapping estimates, and then assign a level of precision to the start date estimate. So this is shown in this slide how this estimated start date algorithm works. So the first step is to extrapolate back to plausible start dates for each concept. And that is performed for point estimate gestational timing concepts such as gestation period 35-week concepts, and concepts that are potentially occurring over a range during pregnancy. For example, a concept that could potentially occur between month 1 and month 3. And then when you work back, you either have a range of plausible start dates for that concept or a point estimate start date for that concept. With the ones that have a range, we then looked for the intersection of those start dates and then found which point estimate start dates occur within that intersection. And then we selected the start date from the concept that occurred latest during pregnancy. So if you remember the scatter plot I showed, where in more advanced stages of pregnancy, there tend to be less standard deviation of when the concepts occur during the pregnancy. We use that information to say that's going to be the most accurate potentially. The start date from that concept is going to be the most accurate. So that's selected as the most logical start date. And then we updated the pregnancy episodes with the new pregnancy start date. And then one of the last steps for the episodes themselves was determining gestational age at outcome. So we find the difference in days between the estimated start date and the date of outcome, or the last date of an episode if no outcome is available. And then check the gestational age at outcome is within the expected term duration for the outcome where it's present. So then we looked at the advantage of using the estimated start date algorithm versus a heuristic approach of just using gestational week concepts without removal of outliers. And we saw a vast improvement in the amount of episodes we have with week level gestational timing based on applying our estimated start date algorithm. We also looked at recorded episode length by outcome category versus inferred episode length by outcome category. So the difference between these is recorded is for an outcome category, what length of time do we have recorded in the data of concepts occurring for that pregnancy? And the inferred is when we actually applied our precise start date algorithm and estimated the outcome date, what is the total length of the pregnancy? And you're seeing that when we infer the precise start and end dates, you're getting a distribution for each type of outcome that mirrors what you would expect to see for that particular outcome. We also performed clinician independent validation. So we selected a random subset of episodes from various categories, such as ones with outcomes or no outcomes. And we obtained good agreement between what the clinicians estimated as whether the episode was present or absent, what the outcome was, and the gestational timing. We also took a selection of 25 clinician validated concepts that were independent to the ones we used to define or infer the episodes, but known to specifically occur during pregnancy at a range of 4 to 10 months. So for example, a concept may occur between month 2 and month 7, for example. And we looked at whether within the episodes, that concept is occurring at the time range, across the time range that we would expect for those concepts. And we got very good agreement, over 90% agreement with those as well. So that was another informatics-based validation of the gestational timing and presence of our episodes. We then added, for extra value, covariates to each episode. For example, what the precise what the inferred pregnancy outcome was, preterm status, and patient demographics. And we performed descriptive statistics of demographics in COVID negative and positive cohorts. And we see this as a great value to the N3C as a resource for any pregnancy and maternity research. So we, using the data release from April, we identified over 600,000 pregnant persons with over 800,000 pregnancy episodes. Majority had known outcomes. Over half had episodes with start day estimates within 1 week of precision. And then we also will be depositing the code for defining the pregnancy episodes to the knowledge store shortly. We also see it as an important improvement in the field. So we have an approach that doesn't rely so much on hard-coded concepts or predefined concepts, such as the study that we had based our algorithm, our initial part of our algorithm on. We really have an approach which allows you per EHR data set to validate what concepts you're using to define your episodes. And also we leverage both concepts that occur over a time range during pregnancy, as well as point estimates of gestational timing, a lot better than previous studies have done in defining or inferring pregnancy episodes. So with that, I'll pass it over to Crystal to share a use case. Let me stop sharing the screen. Okay. Over to you, Crystal.
Thank you, Kate, for describing the cohort construction algorithm. So then I will present a case using our pregnancy cohort that defined using the previous described algorithm. So just give them a minute to share the screen. So we used pregnancy cohort defined using N3C data to evaluate the vaccine effectiveness among pregnant persons. For this objective, we have two sub-aims. The first one is to compare the COVID breakthrough or incidence rate between pregnant persons who are vaccinated and who are non-vaccinated. And our second sub-aim is to compare the COVID breakthrough infection rate between vaccinated females who are pregnant and who are non-pregnant. This is a retrospective cohort study. We're using our study period is from December 10th, 2020 to December 25th, 2021. The exposure for this study is COVID vaccination status for the first aim and the pregnancy status for the second aim. Our principal findings including, firstly, pregnant persons who are vaccinated have lower risk of COVID incidence infection compared to the people who are not vaccinated. And pregnant persons who had vaccination, they are still having higher risk of breakthrough infection compared to people who are not pregnant. So previously, there's many studies analyzing COVID vaccine. So for general population, COVID vaccine have been shown to be effective to reduce the COVID infection rate. But for pregnant persons, they appear to have higher risk of COVID infection, and they are more likely to develop severe COVID outcomes. COVID vaccinations has been shown to be safe for pregnant persons, and without major adverse birth outcomes such as preterm birth. And studies have also shown COVID vaccination can reduce the risk of COVID infection for pregnant persons. But for COVID breakthrough infection after vaccination, there's only one study looking into this outcome, and they also find that pregnant people tend to be more likely to have COVID breakthrough infection. So there's two gaps in the previous literature in knowledge. The first one is that previous studies about COVID infection for pregnant persons are mainly preliminary studies or had minimal geographic diversity or only limited to certain time period. So those stuff will limit the generalizability of those studies. The second one is that there's only one study assessed the breakthrough infection risk among pregnant persons. But vaccination timing regarding to pregnancy, such as before pregnant or during pregnancy, is not considered. And also pandemic variant stages, such as Delta or Omicron, was also not considered. But studies have shown that different variant may also impact the effectiveness of vaccine. And for pregnant people, their immune system is also changing through their pregnancies. For our study, we used the data version 60 that released on January 20th, 2022 to filter out the cohort within our study time period. And we have several time points that are important in this study. The first one is the December 10th, 2020. We choose that to be our study start date is because that's the FDA vaccine approval date. So after this date, people can start getting COVID vaccine. And June 20th, 2021 is the Delta dominant variant point. December 25th, 2021 is the Omicron variant dominant point. And we choose that as our study end date because our study did not include Omicron period. And we include everybody who had a visit occurrence record during our observation period. And we only include healthcare sites that with vaccination proportions above the bottom quartile. Because we have two sub-aims for this study, we have two cohorts. The first one is focused on pregnant persons. And we divide the pregnant persons into three groups. People who received the vaccination during pregnancy, received vaccination before pregnancy, or those pregnant people but without any vaccination. Our second cohort focused on people who are vaccinated, age 15 to 55. We also divide them into three groups. The first two groups of vaccination during pregnancy or vaccination before pregnancy is the same as the subgroups in cohort 1. And beyond those two groups, we have another group in cohort 2, which is the non-pregnant females but who are vaccinated. So this figure shows the details of how we constructed our cohort. I won't go through all the details line by line, just to show the basic methods that we use. The first one is to filter the people who received, who have records during our study period, and then people who are within sites that above the bottom quartile of COVID vaccination proportion. And then among the pregnancy cohort, we divide into those three groups, who are pregnant and no vaccination, vaccinated before pregnancy, and vaccinated during pregnancy. Among people who are vaccinated, we have those three groups of people, and people who are vaccinated before or during pregnancy are the same between cohort 1 and cohort 2. So for our exposure definition, for the first analysis is vaccination, because we are comparing pregnant people who are vaccinated before or during pregnancy and pregnant people who are not vaccinated. For our second analysis, our exposure is pregnancy, and we are comparing vaccinated people who received the vaccination during or before their pregnancy and people who are non-pregnant. For the outcome, for first analysis is instance or breakthrough infection. Among those who are vaccinated, our outcome is breakthrough infection, which defines as the COVID infection after 14 days of their COVID vaccination. And for those who are not vaccinated pregnant persons, we use their COVID infection days after 14 days of the vaccination approval date, which is December 20th, 2020. We use this vaccination approval date as a proxy for the COVID vaccination date because for this group, they did not have vaccination. And for our second analysis, our outcome is breakthrough infection, which is defined as the same as above. COVID infection 14 days after the last date of COVID vaccination. We further divided our study into two parts, which is among fully vaccinated people and among partially vaccinated people. So then another part of our outcome is time at risk, which is the exposure time. I also described time at risk for those four subgroups of our study cohort. For pregnant persons who are not vaccinated, their time at risk would be calculated from their the vaccine approval date plus 14 days, which is December 24th, 2020, until their COVID infection date. And if they didn't have COVID infection, then their time at risk would be from December 24th to their maximum visit occurrence date. For those who received the vaccination during their pregnancy, their time at risk will start at their vaccination date plus 14 days, and until and their time at risk would end at the breakthrough infection date. And similarly, if they didn't have breakthrough infection, their time at risk would end at their maximum visit occurrence date. This logic is the same for the people who received vaccination before pregnancy or people who are vaccinated but without pregnancy. I point out a gray dot in among the groups who are pregnant. The gray dot represents the possible pregnancy end date. The pregnancy end date can happen before they have the COVID breakthrough infection or COVID infection, or after the infection, or they can still be pregnant even at our study end date. So the pregnancy end date did not impact our calculation of time at risk. Then we also include other COVID severity measures as our outcome, including COVID-related hospitalization, intensive care unit admission, ECMO, and 30-day mortality after COVID diagnosis. So in our study, we also controlled for some other covariates, such as social demographic variables, as age, race, ethnicity, region, insurance, and we also considered their health conditions, such as comorbidities, including hypertension, asthma, cardiovascular disease, and their Charlson comorbidity index, and whether they have prior COVID diagnosis before their vaccination or before the COVID vaccine approval date. We use the Cox proportional hazards model with extensions for our study. We clustered the standard error at data partner site, and we stratified our study by the Delta variant periods, which is pre-Delta and post-Delta on June 20th, 2021. We include a set of models for our statistical analysis. The first one is unadjusted model, which only includes the variable of interest and the Delta variant stratification. Our second model add on the social demographic information. And for our fully adjusted model, we included other health condition covariates. We also did sensitivity analysis to address the potential bias about cohort selection, because for sensitivity analysis, we restrict to our cohort to the people with at least 2 COVID-19 tests, because it's possible that pregnant people receive more tests than non-pregnant people. So we use this sensitivity analysis to check our results. So here is a descriptive result of the 4 subgroups of our cohort. As we see that among the pregnant people, their median of age is around 30 years old. And for people who are vaccinated but not pregnant, they tend to be a little bit older than the other 3 groups. They're around 38 years old. And for vaccinated people, we see that they have around 11 or 12% of Blacks, and for vaccinated non-pregnant persons, they have slightly higher proportions of Black. Then for their Charlson Comorbidity Index, as we see that for those people with Charlson Comorbidity Index larger than 3, which are the people who are really vulnerable, the proportion of them is relatively very low across all the subgroups of people. But for those non-pregnant but vaccinated females, they have slightly higher proportion of people with CCI larger than 3. For people who are vaccinated, around 80% of them are fully vaccinated. And for people who received the vaccination, as we see here, there at least around 50% of them have prior COVID diagnosis. But for those who are non-vaccinated people, they have a lower proportion of COVID incidence before the vaccination approval date. Here shows the results. Here shows the results of the statistical analysis of our first study. So among the unvaccinated pregnant females, around 15.5% of them have COVID infection after 14 days plus the vaccination approval date. And for people who are vaccinated during their pregnancy, around 6.2% of them have the breakthrough infection. So as we see here, for those people who are received the vaccination, they have lower breakthrough infection rate compared to the unvaccinated pregnant females. And also similar here, they have less events per 100 woman months compared to the unvaccinated pregnant females. The hazard ratio shows very similar results across those 3 different models. The hazard ratio is 0.75 in the unadjusted model, which shows that fully vaccinated pregnant persons have a lower hazard rate compared to unvaccinated people. And when we compare fully vaccinated pregnant people receive vaccination before their pregnancy, we also observed a very similar result. But for partially vaccinated people, although we observe they have lower hazard rate, but the result is not statistically significant. Then this table shows the statistical result of our second analysis. So as we can see from the first column, compared to the non-pregnant fully vaccinated females, pregnant persons tend to have a little bit higher COVID breakthrough infection rate. And they also have higher events per 100 woman months. And the Cox hazard model shows that the pregnant people who receive vaccination during their pregnancy have higher hazard rate for both fully vaccinated and partially vaccinated females when we compare to those who are non-pregnant females. And for those pregnant people with vaccination before their pregnancy, we also observed the very similar results, that they have a higher hazard rate. So then this is the thoughts about COVID infection timing regarding to their pregnancy. So for people who received the vaccination before their pregnancy, around 40% of them have COVID infection during their first trimester. That's among the people who have COVID infection. And there's 44% of them have COVID infection during their second trimester, and 15.7% have infection postpartum. The distribution is quite different among compared to the people who receive vaccination during their pregnancy and the people who are pregnant but receive no vaccination. So among the last two groups of people, most of them had their COVID infection during their third trimester, which is after 28 weeks of their pregnancy. Then the two plots here shows the COVID infection timing regarding to their vaccination time. Among the fully vaccinated people, we see that the median weeks of getting COVID infection after vaccination is 31 weeks for people who received vaccination before pregnancy, and it's 12, and the time is 12 weeks for those who receive vaccination during pregnancy. This distribution is quite similar between people who received the fully vaccination and who received partial vaccination. Then the last table here shows the COVID severity results. As we see here, most of the numbers are pretty low, so we cannot really observe the proportion of them having those events. For hospitalization, we see that non-vaccinated pregnant persons have the highest proportion of people had a hospitalization. Then in general, we see in our study, we observed that COVID vaccine is beneficial for pregnant persons. People have higher risk of breakthrough infections if they are not vaccinated. And vaccinated pregnant persons still have higher breakthrough infections compared to those who are not pregnant, vaccinated females. So we consider pregnant persons as a priority group for booster vaccinations in the future. So that's all of our results. Do you have any questions?
Thanks. Great talk. Any, let's see, questions? So I have a question. So obviously the major take-home message is the, I suppose, not unsurprising notion that people should be vaccinated. And the second is that there's increased rate of breakthrough infections amongst during pregnancy, which was interesting. So are there other, so in terms of obviously this is an observational study, so I'm not suggesting that we're going to make clinical suggestions on the basis of it, but are there sort of thoughts as to what one might consider doing from a clinical point of view, given the study?
Joel, I'm happy to jump in with some thoughts. I think the first thing that we're comfortable moving forward is saying that pregnant persons should be included in prioritization groups for booster vaccines. So at the moment, they're not. There are other groups, such as people living with immunosuppressed or compromised illnesses or diseases that are prioritized, such as people with really severe CD4 count, rheumatologic diseases, solid organ transplant recipients, etc. But pregnant persons aren't in that group. And what we're finding and others are beginning to show is that this group is perhaps just as vulnerable, at times maybe even more than these other classically immunosuppressed compromised groups. So I think one is to add them to that priority list. The second is, to be quite honest, none of us really know what is the best way to protect our populations against emerging variants for COVID. At the moment, the consensus is moving towards annual vaccination approaches akin to influenza vaccination. But I personally am entirely humbled by this COVID pandemic and acknowledge that I don't know, and I'm not sure most people know what is exactly the best approach. So if we move towards vaccinations toward, maybe there are some groups of individuals that move towards getting vaccinated 2 times a year. And this, pregnant persons might be included in that type of prioritization group. Does that help you?
No, that's interesting. Yeah, no, that makes a lot of sense. So do you have a sense as to, interesting point about comparing to immunocompromised groups. And there was a really good talk probably about a year ago where the actual relative risk or hazard ratio was not as much increased as I would have thought in many of those groups. It was like 10-20%. It's just kind of from memory. I couldn't defend that, but it was significant, but not sort of order of magnitude sort of thing. And is your sense that this, so what you're seeing might actually be greater than that as your implication?
Yeah, Joel, I think that might actually be part of our the immunosuppressed compromised group work that Jing Sung may have presented. And there, I too am forgetting the exact figures, but I think our bone marrow transplant recipients were the highest group at risk, and their relative risk was, for example, 3.6 times that of the non-immunosuppressed group. So it varied highly. But there was market risk. We haven't done head-to-head comparison with pregnant persons within N3C. Crystal briefly presented data from another analysis, but it will be interesting to compare.
It would be interesting. Well, as I recall, right, there was the if you actually suppress somebody's immune system, you got a big increase. But then if somebody has say rheumatoid arthritis or some disease that has an immunological basis, it was that's where I'm recalling the 10 or 20%, but I couldn't defend it. But I agree, if you immunosuppress somebody, it's much higher, obviously. So, well, this is really very in very sophisticated analysis of pregnancy. I'm sure that will be useful in many studies. Are there any other questions? Okay, well, I want to thank you for some great work, and look forward to hearing how it evolves. And obviously, it has a tremendous potential clinical impact. I agree; it makes a lot of sense to think in terms of boosters, but I guess we'll leave that to the clinical studies and clinicians. Okay, thanks. Take care, everybody.
Great job.
Thank
Bye.
you.